Passed, so we'll make a start, and as you just saw, the recording has now started. So Paola, did you want to kick off with any details, or do you want me to just jump straight in?
I will probably just say welcome everyone, and this is the Diversity in Data working group session. In particular, we will be focusing on ethnicity coding standards, and I will basically just hand over to Ashley, who kindly is chairing for us today. And just wanted to mention that the other chair of this meeting is Kamlesh Kunti, who's unfortunately unable to attend today, but Ashley will do all of the artwork for you. And just to say, I am the Alliance Head of Strategy and Engagement, and I've been supporting the Alliance program of work. And this particular working group has been one of the outcomes of our Alliance board meetings. So just very interested to bring together the community of data custodians, researchers, and the public to discuss these important topics. And hopefully we will come up with some recommendations in the area of ethnicity coding standards and organization of definitions, the more terminology of using high quality data. So I'll just hand over to Ashley, and please feel free to post any questions or comments in the chat. And we're just recording for note-taking purposes, and we'll delete after we'll share the outputs of this meeting. Thanks all for joining today. Ashley, over to you.
Brilliant, thanks. So hopefully everybody can see my slides now. Just shout if not, otherwise I'm going to assume everybody can see them. So yeah, just a quick little bit of housekeeping. As mentioned, so the session's being recorded. Please mute microphones if you're not speaking, although we would encourage you later on to unmute and put your hands up during the discussion, breakout sessions, and any questions for the speakers as well. And while the speakers are talking, if you did have any questions, then feel free to pop them in the chat and we'll pick those up as we're going or at the end of the presentations as well. So just to say thank you for everybody for attending today's event. I'm going to give you a very quick fire intro to the session because I'm keen to have as much time for the speakers and talks and the breakout discussions as possible today. So I'm just going to go through a few details with you now. So just to say, for those who aren't aware, we ran the first one of these workshops back in January. It was a really great workshop. We had lots of discussions around diversity in data and specifically ethnicity data encoding. Some of the challenges and the things that we discussed are up on the slide. And just to say, I'm not going to read through all of that because all of this is on the website that was shared after the last event, along with a recording of the workshop and all of the presentations and the report collating all the key findings and actions from that. So if you are interested in having a look at what happened at the last workshop, then please go to the website and have a look. And also the same will happen after today as well for anybody that was unable to attend today. So just to bring us back together really as to why we're here today. So this is a similar slide to what we shared at the first workshop, but ideally these are the types of things that we're looking for when we would like to use ethnicity data. So we'd like it to be complete, we'd like it to be usable and accurate, we'd like consistency, where possible we'd like granularity, and we'd like comparability between data sources and within data sources as well. And really bringing us on to the topic of discussion today around standardization or standardizing ethnicity coding. So the first question really we need to ask ourselves is, well, why might we want or need standardization? So just building upon that last set of points there. So standardization is really important where we might want repeatability or reproducibility of our findings, whether it's within a data source over time or longitudinally, but also as we start to look across different data sources or settings and systems and platforms and different types of data collections. So it's really important now as we get the benefit of our expanded data infrastructure, how can we use these data as best as possible? With that challenge, but opportunity, comes consistency. So how can we ensure that the measurements we're looking at and the findings and outcomes we get across our research and intelligence means the same thing? So are we comparing apples and apples, or are we comparing apples and oranges? We need to be clear about what we're talking about here and what does it mean then in terms of how we translate those outputs into services and improvements for people. And lastly then, how do we improve the usability of the data we already have? Because as we mentioned already, there's a wide range of data already being collected across the UK in lots of different systems. but it collected in very different ways. So how can we improve that, the usability of that? And also a goal of this group is to potentially then improve standards or frameworks for further data collection. So moving forward, how can we improve our data collection moving forward? So just to sort of go on the other side of the fence here, why might we not want to over standardize our data? So whilst it's great that we could potentially standardize or aggregate our ethnicity data, say, into ethnic groups, which will allow us larger numbers, will allow us to have that consistency, will allow us to have that harmonization or increased consistency, we do need to be sure, or we do need to ensure, sorry, that we retain that higher granularity when it comes to different ethnicity information, because we don't want to lose that diversity when it comes to different populations that we might want to do research on where it really is needed in the future. So just to say, there is a balance to be had here. It's not an all-in, let's just standardize everything and lose our granularity. We have to be cautious about what we do and how we go about it, and the reason for going about it as well, just to say. And really then, what are some of the considerations around the challenges with ethnicity data in particular? And just to be clear, these are not all of them. These are just a few, just to get people thinking about things for the breakout session later today. So as an individual, you or I may choose to change my ethnicity over time. So how do we deal with this when we want to do longitudinal research where a person chooses to define themselves as one type of ethnicity one day, and then later in time they change their mind and they change what they feel their ethnicity is? Where people declare their ethnicity differently. So how do we interpret potentially in one data source where there was one type of ethnicity code or classification available that was not available in another data source, so they define themselves differently elsewhere? So how do we interpret these data from different settings and collected for different purposes as well? A really important point now as we start to expand on the amount of data we have available, how do we deal with individuals who choose not to declare their ethnicity? So how do we handle for missingness versus people who choose to withhold their ethnicity for whatever reason? How do we start to deal with some of these challenges now as we expand the portfolio of data we have available to us? And one which is coming up more and more now is around, well, what do we actually mean by ethnicity? And do people or individuals realize what they're being asked to declare or to provide at a certain point in time? So there's a conflation sometimes, or a misconception around terms or terminology where ethnicity or race, lineage, nationality, country of birth, and other concepts are all kind of merged into one, and people just think that they're the same thing, or they don't know the difference between them. But we really need to understand this so we can better differentiate and understand different types of information we're receiving from individuals over time. And also so that the individuals themselves know what we're actually asking them to provide to us. So as I said, that was just a very quick whistle-stop tour through what we've done previously and what we're hoping to discuss with everybody today. I'm really pleased that we've got a couple of great speakers with us today, and I'm going to hand over to the first of those speakers now, which is Rose and Cameron from ONS, Office for National Statistics. We're just going to give us a 10-minute talk on some of the work that they're currently doing and that they're proposing doing in the future. So I can see Rose already sharing a screen. So yeah, Rose, over to you when you're ready.
Sorry, actually, I didn't mean to go too quickly. I was just trying to make sure I had all the buttons in the right order. Didn't mean to interrupt you there.
No worries, over to you.
Thanks very much. I'm Ms. Drummond. I'm the lead for ethnicity analysis in the health analysis team in the Office for National Statistics. And I'm here with Cameron today, who's one of the ONS lead analysts on this project, to talk about a project that the ONS is delivering in collaboration with the Wellcome Trust around assessing the quality of ethnicity data in key health admin data sources in England. So the background to this is kind of during the COVID-19 pandemic, we saw early on kind of elevated risk of COVID-19 mortality in some ethnic minority groups. And it became really urgent to understand ethnic health disparities. So analysts in different organizations produced analysis using the data available to them. So that might be, for example, Public Health England using ethnicity from hospital data. Some analysts had access to Open Safety and the GP data, could use ethnicity information from that. At ONS, we used census data, which is widely regarded as the kind of gold standard for self-reported ethnicity. But of course, that was 10 years out of date, so it also had its own data limitations. And the question this project really is about is, when analysts have access to different data sources with different biases in them, different levels of coverage, different levels of completeness, how do you go about kind of comparing and having a coherent picture across these different studies based on different sources? So there's two things we're doing as part of this project. The first is about assessing data quality in these individual data sources. And then importantly, the second part is around developing estimation methods that will help us account for some of the biases in the underlying data. Fitting in with this theme of, I guess, laying the groundwork for harmonisation and thinking along that side. There's 3 work packages as part of this, all trying to answer basically the same research question. The first work package is being led by the ONS, and it's desk research on the data collection systems and processes. The second work package is also being led by the ONS and is kind of quantitative person-level comparisons of ethnicity recorded in each of these data sets and comparing that against census data. And my colleague Cameron will speak more about that in a few minutes. And then the third work package is being delivered by a third party. So the Race Equality Foundation are running a series of focus groups with healthcare staff who collect ethnicity information and with members of the community to find out about people's experience of being asked their ethnicity in healthcare settings. Do they understand why that they are being asked for this information? Do staff have adequate training? And again, touching on the point Ashley mentioned earlier about kind of how ethnicity, how people self-identify, how that might change over time. So, data sources that we are focusing on are the hospital episode statistics, the hospital data, GP data, and then there's a newish data set that's been created by NHS Digital, this COVID-19 ethnic category data set, which brings together kind of all the GP records, ethnicity from GP records, where ethnicity is missing in GP records, it then uses hospital data or ethnicity from hospital records to kind of improve completeness. So we'll also be looking at that. And then where it's been available, so for part of the research, we're also looking at the improving access to psychological therapies, IAPT data, which is about community mental health. And then these are kind of being compared to self-reported ethnicity from the census. So as I mentioned before, the first work package that ONS is working on is this desk review. Main research aim here is to describe the practical methods of data collection, understand the IT systems, how it works in practice, where the known difficulties are, and where, importantly, the potential sources of error and bias might be coming in, so that as analysts, we can understand that and see what methods might be appropriate to account for that. So the approach to this is really, we've been doing a literature research and then conducting expert interviews with kind of GP practice managers, contacts at NHS Digital, people that kind of work on data collection standards, IT systems providers, to really get a full understanding of that process. And then I'm going to hand over to Cameron now to talk about the second work package, which is on quantitative research.
Hello everyone. So yeah, the work package 2 that Rose mentioned, we're going to predominantly broadly examine ethnicity coding between the data sources that's previously just been mentioned and identify potential differences between these sources. So the sources were, if we just quickly go back to the last slide, it's a bit small, but yeah, so we'll use census as sort of the gold standard, 2011, and then we'll compare this to HES data, so hospital data, and the 3 sources within that, which are APC, AE, and OP data sources. We'll do the same for the GP data, and then also the NHS ethnic category information asset. And we won't do that on currently on the IAPT. So yeah, I'm happy to go to the next slide now. So with the work package 2, we're going to split this into sort of 2 publications. So The publications can be in any format. It could be ONS reports. Also, we plan to submit academic papers, potentially technical reports, or in sort of the form of a guide book for analysts who are dealing with different data sources, data sets. So predominantly publication 1, as it says there, will focus on how can we get the most reliable person level ethnicity derived from health admin data, but also describe descriptive differences between these sources and how ethnicity is recorded, and then what are the predictors potentially that may explain missingness or may explain the likelihood to be in a not stated ethnicity, and try and understand a little bit more about, you know, the distributions of these groups. And then with publication 2, it's much more focusing on the impact that potential biases may have on outcome estimates, so for example COVID mortality, and then also developing methodology to account for the bias. Yep, next slide please. Okay. So a little bit more detail on what we'll actually be doing in these two, or in this work package and these 2 publications. So as I'm sure many of you are aware, you know, many individuals within health admin data have more than one ethnicity record in their records, and this could be from many different data sets on different dates or the same dates, and this provides a sort of a component of complexity when deciding what to do. This means different people who are dealing with the data can implement different rules when deriving their ethnicity sort of rules, and this adds variation when trying to make comparison between studies. And this can even happen when using the same data source, for example. So what we will aim to do in publication 1 specifically will be extracting ethnicity information. So for example, do we want to use recency ethnicity or modal ethnicity? So obviously the most recent date or the most common ethnicity. You know, do we prioritize certain data sets when choosing this, for example, whether we use GPES or HES if they have ethnicity data from the same date but different data sources. Yeah, handling of the overcoding or other data sets. How do we deal with people with others? Do we, for example, if they have a previous ethnicity recording, do we choose that, or do we stick with other, and understanding a bit more about, you know, the population that are actually sort of listed as other? Is there anything specific about this group that's worth noting? For example, is it all concentrated in a specific subset of society, or you know, are they young, are they old? Just to get a bit more granularity on these groups. And then within publication 2, it'd be more around handling missing data and the methods of sort of most suitably handling this data. So happy for the next slide. And then ideas for future work. So I think obviously a really useful one will be when the 2021 data becomes available to repeat what we've done with the 2021 census. But then, as Ashley touched upon in his introduction, we actually want to see potentially individual level changes between the 2011 census and 2021 census, and understand, you know, how does an individual potentially change over time, if there are any changes, and you know, the impacts this may have. And then lastly, we want to further explore methods to account for bias. So I think this would include, but not be restricted to, looking at a wider range of factors and methods to help us greater understand ethnicity coding. So for example, looking more at specific age brackets and understanding the differences, looking at first, second, and potentially third generation people, and looking at whether there is intergenerational differences between ethnicity coding or how they identify. Exploring a wider range of factors, again, what Ashley touched upon, but you know, including factors such as religion, national identity, country of birth, and using this data to help untangle potentially ethnicity coding issues that we see in improving the standard across ethnicity coding. And also, sort of lastly, just understanding from everything that we said here today, you know, how does this actually impact outcomes, and a variety of different outcomes, when we actually do research and we're looking at certain things, whether that be COVID-19 mortality, infection, cardiovascular disease, cancers, whatever, and just understand, how does this difference in ethnicity change anything, if it does at all. And that's it. I think that's our presentation done. So there's a few minutes now for questions if anyone has any. So would be happy to answer them.
Brilliant. Thanks, Rose and Cameron. We're just going to hold questions for now and jump straight into the next presentation. But if anybody's got any question for Rose or Cameron, feel free to start popping them in the chat or keep them until after the next presentation. And Sarah, if you're here and you're able to share screen, if you can jump into yours, and we'll do the questions straight after the next presentation. Thanks both. Sorry, you might just want to switch it out of presenter mode. We can see the other screen at the moment.
Yeah, just bear with me a moment. How exactly do I do that?
If you click display settings, you should be able to switch it over. Top.
Apologies, this is what happens when you're used to using just Teams and not so much Zoom. Is this any better?
Yeah, that's perfect. Thanks,
Lovely.
Sarah. Over to you.
Amazing. So thanks very much. Thanks for the opportunity to present today. And I have to say in advance that my slides are nowhere as neat and slick as Cameron and Rose's, so rather hastily put together. But hopefully you'll bear with this. And then also just to credit Martha Pineda, who's been the postdoc working on this analysis. So I'm just the person who's doing the talking today, really. Okay, so just by way of background, this work is part of a data and connectivity study that was funded through the HDR UK and Alan Turing Institute, and we're looking in that study on overall the idea of bias in ethnicity data from an artificial intelligence perspective, and how we can kind of try and minimize certain biases. So as an example, if you look at any artificial intelligence healthcare technology, there can be many sources of bias, mainly creeping in the form of either the underlying data that goes into models, or the models that are used to create any artificial intelligence algorithm, such as an health assessment calculator and so on. And if there's bias in any of these main two stages, then that can lead to lots of issues, such as incorrect assessment of health risks, and over prioritization or under prioritization, ultimately, of ethnic and racial groups, as to say the least. So the objectives overall for this work were to try and see if we can improve on the correctness and completeness and granularity, some of the things that are the theme of today's meeting with respect to ethnicity information in routinely collected data, and then as a secondary objective to then see, once we have cleaner, maybe more granular ethnicity groups identified, to build specific ethnicity specific models for them, and whether or not those models perform any better than existing more vanilla models. And so to do this, we are looking into we're focusing in two data sources from the UK TRE environments. Today's talk is focusing on the NHS digital TRE, and then we plan to kind of try and validate what we do in SAIL as well. But looking within the NHS digital TRE, this is, of course, an environment that we have been granted access to through the CVD COVID UK consortium, and the data sits nicely within the NHS digital secure environment. And within that, it can be accessed using the Databricks environment. So what we've been doing in terms of wrangling, or basically exploring the data as it sits in the DAE, is to try and see, first of all, developing understanding of the data that is already there. And when I say data, we're basically just talking about ethnicity data at the moment, and to try to develop an understanding, a good understanding of what the recorded data represents, really. And then secondly, to see if there are issues with quality and whether or not we can improve on it in terms of accuracy, completeness, and granularity, and so on. So in terms of the data sitting inside the NHS digital DRE, one could think of it in terms of mainly 3 types or buckets or layers. So there is and I should say as a disclaimer, these are the data that we have so far been looking at. This is not to say that these are the only data that there are in the TRE. There are a host of other tables as well. So, but we've been looking at GDPR, which represents the main primary care data set. Within that, ethnicity and racial concepts are captured within what may be called as primary codes. So these are codes that follow an A to Z notation, have been adapted from ONS, from the ONS census standards. GDPR also contains sort of raw SNOMED codes that captured ethnicity and racial information. And then linked to this is a hospital data, such as from the hospital admission statistics, which is also recorded in the form of the same primary codes, the A to Z notation. So the HES data does not contain SNOMED codes. Then there is a further kind of grouping that you can find within the NHS digital TRE environment. But this one is more something that is based off of secondary analysis, mostly done by other research groups such as ours, where they've taken the primary code data or SNOMED code data and grouped them into buckets of, for instance, white, mixed, Asian, Black, others, and the unknown category, which is then the basis for most of the research that has been happening within the NHS digital TRE. So perhaps if I try to, or maybe I shouldn't, given my lack of Zoom expertise, I'll stick with the PowerPoint really. And so in terms of the primary codes, they've this is what they will look like. The primary codes have evolved over time, obviously, as have census classifications, as Rose was describing. So, the categories have evolved and changed slightly from 1995 to 2001, and then from 2001 to 2011. Where 2 further categories were added in terms of the Gypsy and Irish Traveller and Arab ones. And then there are the SNOMED codes as well. So we found that in total there are 489 SNOMED concepts available in the NHS digital TRE. Of these, some 255 are used, i.e. there are individuals in the TRE whose records contain any of these 255 codes, and then there are the rest of the 234 ethnicity concepts are not used, which is unsurprising because there are very many SNOMED codes in the data set, but not all are necessarily used. So all in all, the numbers that we've been sort of digging into so far are something like this. So in total, within GDPR, there are about 61 million records for 61 million individuals, of which there is a category of individuals for which no ethnicity records exist at all, and so this was for us a chance finding, but it's probably well documented elsewhere in the TRE, and this number it goes up to 10 million or so. So it's not insignificant. However, our focus thus far has been on the box bordered in red, which is anyone who's had an ethnicity at least one ethnicity record, either in the form of a SNOMED code or a primary code within the GDPR and the TRE. So this is around 51 million individuals. Within these within this category, there can be people whose ethnicity has been recorded in the form of primary codes, so using the A to Z notation, or in the form of SNOMED codes, so any one of the 489 SNOMED codes. And within these two classifications is also captured an category for missing ethnicity. So you might have an ethnicity record, but it might say that your ethnicity is missing. Essentially, it's not been recorded or self-reported for one reason or another. Some of the reasons were touched upon by Rose and Cameron. And so we found this to be about 1.6 million, the case for about 1.6 million individuals. So this plot, which is basically you can't read the text on it because at the bottommost, let me try and navigate this a little bit. The bottommost layer is a summary of those 489 SNOMED codes, color coded according to how they map to the primary codes, the A to Z codes, also captured within the TRE. And so this is kind of like a depiction of how the mapping works within the TRE. So at the bottommost layer, we have the SNOMED codes, and the intermediate level, we have primary codes that are present in the TRE. And then at the topmost level is the high level grouping that is, more research oriented or has been sort of devised for research purposes, which you see across a lot of the literature, 5 to 6 categories that are seen. Now, in here, something that we've also come across is some potential sort of discrepancies, as this was one of the things we were looking into. So we found that, for instance, as an example, if I just zoom in now into one of these areas, what we're looking at is SNOMED codes corresponding to or mapping to the group called other ethnicity or other ethnic groups at the primary code level. And then here we find that a potential discrepancy such as Gypsy or Irish travelers and Chinese, the SNOMED codes for Chinese being grouped into the category other, which may not necessarily be what you would expect to be the case. In fact, we now know that as per the census classification, the Chinese, any SNOMED codes or primary codes corresponding to Chinese should fall within the Asian group, for instance. But this is just a small example of some of the maybe sort of nitty-gritty things that we've been looking into and have been spotting. This is another example, for instance, of where we've seen for those interested in mapping, for those interested in working at the level of SNOMED codes and maybe how they map to primary codes. Here we found again some examples of where, for example, of potential misclassification. So, for example, Asian Chinese, the SNOMED code category Asian Chinese was mapped to other as well as Chinese and white, New Zealand European, Buddhist, British ethnic minorities. All of these have been mapped to the ethnic category other, again, which seems counterintuitive, and we know that these categories might be better mapped to some other groups when it comes to it. So in summary, so far, what we found is that 51 million individuals with at least one SNOMED code or primary code for ethnicity, there's data for that within the NHS digital DRE. We also, of these, about 1.6 million individuals are recorded as having missing or not reported ethnicity. And then, one of our interests was to try and see whether there are large enough sample sizes for some of the more traditionally considered as smaller ethnicity or minority ethnicity groups in UK data. And so just to give a flavor of what the data are kind of starting to look like, we can see that, for example, if someone was interested in doing analysis with individuals ascribing to ethnicity Sri Lankan, then there is about 80,000 individuals, data for 80,000 individuals with that ethnicity. Similarly, 50,000 for ethnicity Ethiopian, and 30,000 for Filipino, and so on, just as an example. I mean, but this is still very much work in progress. So a few key things that we have still to kind of work around. One is the fact that we started out with looking at individuals who had at least one ethnicity record. So those 10 million people in the flow chart, a couple of slides above, for whom there was no ethnicity record, are not included so far in these analyses, and we're now looking to extract their data as well and compare the two groups. So to understand, with a view to understand whether there is something in baseline characteristics of the two groups that can help us understand why, for instance, someone's ethnicity may not be recorded in the first place. Secondly, we've so far restricted our wrangling, if you will, to the most recent record. And we know from the previous talk that there are obviously individuals and episodes with multiple ethnicity records in the data as well. And so in terms of some of the things that are going on in the background with a lot of intensity are some of the things that actually Cameron mentioned in his concluding slides, and that is, how do we sort of handle cases where the ethnicity is not very clear, right, or the self-reported ethnicity is not very clear or standardized or harmonized. So do we look back in case of multiple records just within GDPR and try to look for most recent, most frequent, and so on? If the ethnicity is still missing just within GDPR, then we consider looking at linked records from other tables within HES and other data sets, such as the ones that Rose and Cameron mentioned. If it's still missing, then perhaps consider methods for missing data imputation and so on. But I probably want to leave it there, and just with a message to say a few people have expressed interest in this activity, and we are very open to collaboration. And in fact, I think collaboration is the word of the day, because a lot of our collaborators are on the call as well. We are working on a preprint if people are interested. It should be out soon. And then just a quick shout out to not just the people in the study team, but also to Ashley and Kamlesh and Angela Wood and a lot of people in the TRE and in the CVD UKIT consortium, as well as nationally, who've given us a lot of feedback, as well as Rose's team in the ONS for very engaging and useful discussions. So thanks very much, Ashley.
Brilliant, thanks, Sarah. So two really great presentations there. So if anybody's got any questions, feel free to start popping your hands up or popping them in the chat. I've got a couple of questions. I can see one from Duncan, who's just asking, Rose and Cameron, thanks for sharing your work. Do you have a rough timescale for when the work might be coming out?
Yes, of course. So we're seeing this as a kind of a series of releases. So the first will be coming out over the summer, kind of, I'm not going to say June, July time, but there'll be more following after that, I think is what I'm going to say. So yeah, the first one's coming out soon, starting with kind of work package 1 and publication 1 that Cameron described. But yeah, some of the extension work is not yet even started. We don't yet have access to Census 21 data, so that's still to come.
Yeah, thanks. And just as a bit of a follow-up question to yourself and Cameron, so this is probably going to be a really hard question to answer, but You mentioned the word reliability a couple of times in the slides. So how do you plan to define reliability, or how do you plan to quantify this in terms of the data you're using or you have access to?
It's a really tricky one. So I think for this, it's about, I guess the first step is looking at comparability. So where we've got different studies using different sources, being able to use methods so that, you know, if I've used one data source and you used another, we both do analysis and we want to be able to see if our results are comparable using methods that account for the biases in the underlying data. So that can be done through the comparison work that we are doing. The question on reliability is a really tricky one, because I don't know where you can start on that in terms of kind of data collection. I don't, Cameron, if you wanted, I can see you unmuted if you wanted to come in on that side as well, or if others in the room have thoughts.
Yeah, I mean, obviously reliability is really, you know, difficult thing to do, and probably the wrong term, to be fair. Pretty sure I would have used it. But I mean, even using census as the gold standard, but clearly that has its own issues, and it isn't the perfect, you know, it's not the perfect data set for ethnicity classification, but that's sort of, at this point in time anyway, what we think is probably the best. So it probably more just meant comparing it to that, and then, you know, obviously acknowledging that clearly there are issues with that, even to do that, and then building upon what Rose mentioned, you know, more about comparability and, you know, taking it a bit further. And you just, yeah, even with the 2021 census, which would be much more recent, we can, you know, hope that that is more, I guess, is a better word, valid in terms of measuring what it's supposed to be measuring. But still, there's going to be issues around that in terms of, you know, lots of things that I know we've spoken about in our previous meetings, but around, you know, the situation when someone could fill in the census could massively affect how they put their ethnicity down, for example.
Yeah, thanks. And then a question for Sarah. So question from the chat. I noticed that primary code A to Z only sorry, I'll start again. I noticed that primary code A to Z only from SNOMED codes in the figure. What will the overlap be between them?
So could you rephrase that for me, Ashley?
It's not my question, so I'm not sure if the person in the chat wants to just come in and unmute and ask the question themselves.
So I'm trying to understand the overlap between the primary A to Z categories and.
So hi, it's my question, Sarah. So I wanted to understand, you know, in one of the figures you showed, the primary A to Z codes only partially overlap with the SNOMED. So what kind of overlap is it? Is there more in SNOMED which does not overlap with primary, or
Yep.
do you know any numbers?
Yeah, so yes. So there was a slide on the numbers. There's about 29 million with the primary records with the primary, whereas there is about 43 million records with just SNOMED codes. But if you link the two, then you could go up, the number goes up to around 51 million. So we found that there's a lot more information in the SNOMED codes. Not all individuals have primary codes in the TRE.
Sure, thank you.
Thanks for the question. So I'm just jumping through a few, and then we're going to jump into the breakout sessions. So there's a question here from Claire. So thanks to all the speakers for their presentation. So research using HES data is currently limited to the 2001 census categories, which are available in HES. Are you aware of any work being done to update HES to reflect more current census categories? Either of you want to take that question?
So I'm aware that conversations are happening. I'm not the right person to be able to provide an update on where those conversations are at, unfortunately. But yes, NHS Digital are well aware that that is kind of an old set of census categories, and they are looking kind of towards what can be done in that space. Not a very helpful answer, sorry.
Yes, and exactly. And so the 2011 categories, as it were, have been added and are there to see in the data. But most research has been restricted to the 2001 categories. However, the categories from 2011 have made their way now into the data that we find in the TRE.
Brilliant, thanks. And then I've got a quick question for Sarah. So, and kind of overlaps with a question from the chat. So you mentioned about the use of artificial intelligence in your early slides. And somebody here asked a question with regards to, can you give any examples of the data and any algorithm biases found in ethnicity data? But if I just summarize in terms of my initial question, sorry, what do you think the advantages or the opportunities are for AI in this space in particular over some of the other standard methods you've already mentioned? So yeah, a good question. I think in at least two different ways. So one is by making the, I'll try to be brief about this, but one is in terms of cleaning up the data. So if we have better and good quality and enough data for so one of the issues that with artificial intelligence technology and its use in healthcare models is bias, right? And bias, it can be biased because you don't have enough training data, or you've not validated on the right population. So the models in a sense are not tailored or well calibrated to the populations of interest. And we saw this in the case of many algorithms, some to do with COVID, others to do with heart disease prediction, others to do with cancer diagnosis, and so on. And it all comes down to there being enough representative data for the population of target population of interest. So with there now being all of this availability of rich and diverse ethnicity data, and it being tidied up and cleaned up such that, for example, we can start to see small, data from ethnic minority groups emerge in large quantities, then models can be developed for those ethnicity groups per se. That's one way to do it. And also, more methodologically, methods like multiple imputation and machine learning methods can also be then applied to try and improve where there have been algorithmic biases. And that's a whole field of research, and we're very active at the moment as well. Brilliant, thanks. So we've got another really great question from Jackie, but I'm not going to ask the speakers to answer it because it's a perfect segue into our breakout session, because it's one of the questions we actually have for each of you in your groups to answer. So I'll read Jackie's question out, but hold off everybody from answering because I'd love you all to discuss it now as part of the breakout. So Jackie asks, is race being conflated with ethnicity to some degree? So when ethnicity is relevant to culture, should we be also collecting race, or would genetic phenotype data cover this better? And that is very much associated with one of the questions we were going to ask in the breakout session. So as I said, that nicely segues me over to the breakout sessions. Just to say thank you again to the speakers for presenting. I think that was a really great set of presentations. And if anybody's more interested in getting involved with the ONS or Sarah's work, please get in contact with them directly, either through the Alliance and HDR or directly. I'm sure they'd be happy to share their contact details after the workshop today. And I'm now going to ask you to move over to the breakout session. Just to say, we've got facilitators in each of the rooms who've got about 5 or 6 questions that we want to talk about today. We're going to give everybody just over half an hour today in the breakout session. So we're going to come back together at about 2:25 for a discussion where we're going to share the key learning points and things that have been discussed within each of the groups. And then have a little bit of a discussion at the end as a bigger group. So just to say then, if the Paula and the facilitators, if you could push us over into our breakout rooms, and we'll get kickstarted with the breakout sessions. So thanks, everybody.
Yeah, Ashley, I've got the groups ready set up and ready to go. I've set for 35 minutes. Are you happy with that?
Yeah, that would be great.
Perfect. I'll open the rooms now.
The session. Great. So thanks to everybody in the breakout rooms. I know we had a really vibrant discussion in ours. So I'm just going to hand over to the facilitators now in whatever order you all want to go in. But do you want to just share for about 5 minutes each, up to 5 minutes each, what you discussed in your breakout room and what were sort of the key discussion points and any key learning to share back with the group?
who wants to go first? So Paola, did you facilitate?
Yes, I did. I'll go first. Thank you. So just to say, we had a very mixed group, very interesting discussion. And actually, we started with one of the questions that were asked during the previous session that was about conflating the concept of race and ethnicity. Then we started to talk about a much wider picture in terms of data collection and the role of the clinicians, but also how people feel about providing information around the ethnicity and similar type of information. And then we finished again with the conflict with the terminology around race, ethnicity, and what we actually mean. So I think what's been said probably during our discussion is that definitely there is a lot of work ongoing in terms of looking at these issues, but a lot is still not being resolved in a way. When we talk about classification, for instance, and when we talk about conflating the two concepts of race and ethnicity, it's been mentioned that even the ONS classification has been criticized because the two concepts are conflated in a way. And so there is something there that can be done in actually define the concept a bit better, but also define the categories themselves. And so how we described ethnicity and the terminology that we use for ethnicity and the terminology that we use for race. Sometimes we use exactly the same word. We say white, I'm white, ethnic group white, and the same for race. So what does it mean if it's actually the same thing? So is there a need for actually looking at how we can describe those better and create kind of a framework that might be used as an initial guidance for people to actually record that information? Then from that, we talked about how that information is recorded. That can be variable. There are some, so all of the forms that we fill in when we go and provide that information might be quite different. And we might be providing information one day and something slightly different another day in other settings. So how we're going to standardize that is going to be important. We talked a little bit about the unknown. So when people are asked about recording the information around ethnicity, sometimes they say, I don't know, unknown. So how can we improve that, providing that better understanding around why this information is needed, what we mean by that, etc. There was an observation about a couple of experiments that I think have been run in the past about incentivizing GP practices to increase information around ethnicity, and incentivizing we mean by even financial incentives to GPs. And when that was done, there was quite an increase in reporting that information that finished when the incentives were finished. Similarly, they ran some training about training practitioners in collecting that information. It went very well until the training was there, but then once the training is finished, let's say that practitioners went back to the previous practice, not talking about it with people in the different practices. So there's something there around training and incentives. And then the public aspect, we discussed the public aspect of this as well, which is particularly important. And so we thought, so now we were saying we need to look at definitions, we need to look at how we explain this better to people. But then there is something, who is going to decide what type of information is needed? Should we ask the people why they feel uncomfortable? There can be a lot of different reasons. We talked about that, and we run through some examples that were not particularly nice, with people feeling that they are discriminated, and we don't want obviously that, but is it a matter of asking people what did they think? Why they're not reporting that information? Is it because they're having some particular perceptions of being treated differently, or is simply because they don't know? Some people just don't know what it all means. And I said as well myself, sometimes I'm unclear really. I just put other because there's no my option. So how we address that? So I think we discussed a little bit of everything. I just wanted to ask the group if I forgot something. I'm sure I did. So anyone else from our group who wanted to add anything? No, thank you. So I hope I captured most of it. Thanks.
Great. Shall I go next, and then Claire and Alice and Holly Dawn? So we had quite a radical discussion actually And I am going to bring my colleagues in who are far better at explaining these things now. So we kind of went from talking about the fact that we're moving more towards a society that self-identifies. So people don't fit neatly into a box. They don't want to fit into a box that we're asking them to tick. And we had a really great chat actually about sort of maybe some of the generational differences as well, and how we need to think those things through. I think the really big thing, and Mavis, I'm going to bring you in, and maybe Duncan and others as well, to kind of talk about this. So we talked very much about needing to think about people in the whole. So asking more around their experience of life, and actually is asking around about race and ethnicity even the right thing to do. Other countries, so it's a very kind of UK, USA kind of approach. Are there other ways that we could think about inequality? You know, are we really tackling kind of inequality? Are we really getting to the crux of what we need by collecting the data that we're collecting? Mavis, do you want to come in and maybe, because this is kind of your specialist field, you've got such a lot of important things to say. So let me just hand over to you to kind of sum up for our group.
Okay, great, thank you. And for sure, I'd like the rest of the group to come in also. I think one of the things that we were talking about was whether collecting ethnicity data is enough as an approach to thinking about inequalities, because we can't just look at just inequalities in health without thinking about the environments and the ways in which people are coming into the health sector. So one way that was radical was maybe we just forget the categorization of people with data and think more about what do we know about the way society is currently arranged, like who lives in polluted areas, who earns who earns the least amount of money, and what does that mean for their ability to participate in health preserving behaviors, such as being able to go to the park if you live in an area that doesn't have lighting and so you can't go out and walk after dinner, or even in the afternoon in winter. If you earn a certain amount of money, that stops you from being able to access the internet, which means you can't see your GP online, so you can't participate in those kinds of technologies. So we can already think about inequalities in that way without necessarily then having to say, well, who is that person? Because we already have the data collected in other ways, and we just have to be clever about how we analyze that. And so I think if we're not going to be looking at health as something that is impacted by, by the ways people experience social care and other admin things in their life, then what's the point really of collecting ethnicity data? Even though I recognize that we do need to start somewhere and categories are important, but maybe we just need to rethink this whole thing and say, what is the point of collecting this data if we can still think about health and social outcomes in other ways based on, say, income and environment?
There we go. Some radical thoughts for the afternoon. Duncan, Cameron, Shikta, does that kind of, so we do acknowledge that we have to start somewhere and that we're perhaps not quite ready for this yet, but other places are doing it. And I think Mavis kind of drew out as well, so she has Zimbabwean kind of heritage, but it's not just enough to sound from Zimbabwe. I am from a particular group of people, and it goes down and down and down, and we drill it down, and we're not even collecting that kind of information. So we're not, we're just categorizing. Mavis says I'm categorized as a Black woman from Africa, which doesn't actually represent who she is at all, or her experience of life. So maybe our group are kind of suggesting that in the future there is a very different way to kind of categorize. And I think Shikta kind of also kind of talked very much about the fact that we don't even have enough ethnicity data often to kind of really analyze the things that we need to do in the first place. So actually the data sets that we've got are actually quite small anyway at the moment. So we're not really kind of getting to the heart of problems, but we do recognize that we're at the starting kind of phase of our journey. So just some radical ideas to throw in there this afternoon. Thank you very much, everyone.
Thanks,
Alice, I'll pass over to you.
Yeah, as I say, you next. So a couple of similar themes coming out of our group as well, and I'll try and be quick, just conscious of time. And people in my group, please do jump in, because I'm not an expert on ethnicity data by any means. So around that first point of how is ethnicity currently captured and recorded, and the variability, we talked a lot about the fact that it depends on the systems that you're using to collect it, as well as whether it's self-reported or whether it's being almost guessed at by the healthcare worker. Are they looking at you and saying, oh, well, you're white or you're black or you're this, and actually not being reported? And also talking a bit about the fact that there's large amounts of data missing on people, and also about that kind of changing self-identification over time of your changing ethnicity. If we're looking at it from one perspective and then it's recorded, how might it be looked at later and in a different context? And it can also be captured differently across the same data source over a period of time. So we're still missing a huge amount of information on people. And this framework would be really, really useful. So on to that next point, it's going to be really key to make sure that we're training healthcare administrators and healthcare workers on how to collect this and have that standardized, because within GP services, you'll look at one in London and they'll collect it in one way, and one in Wales will collect it in a completely different way. And we should be thinking more about how we ask patients directly, and how much of the information is, as we say, collected as a guess or being looked at as one person. We have to accept that some people might not know or be comfortable sharing that, and have to respect that people can say that they don't want to share their data. So that's not missing data. That is someone saying, I'm opting out of sharing my ethnicity data. So they are not part of the missing, and that's just as important as well. And the importance of helping the public and people in a healthcare setting who are being seen by healthcare professionals understand how these categories work, and how to, and actually helping them declare that if they want to do that. So that training is really important, and the mechanisms of capturing it as well. So how we're supporting people to fill that in. Are we asking healthcare professionals to fill something in on their behalf? And then we got a little bit onto sort of a question about all the questions about simplification and aggregating ethnicity. The simplification on the national level can be really useful if you're looking at national trends. But if you want to look at specific groups, simplifying it down so far is not going to be providing you with that much information, and it's not going to be helpful for policy change and to actually make changes for the groups that you want to. So keeping that granular information available to researchers is really important. But we should be able to shrink down and expand up the amount of categories that we're using, depending on what's needed for the different research priorities. And then just on to those final questions about how often it should be captured, and how does ethnicity differ from race, and what other things we should be collecting. If you're asking every patient every single time that you see them what their ethnicity is, asking them to reconfirm, that might not be realistic. As I think some of the other groups who fed back so far have said, it might be a bit disconcerting being asked that, and people might not want to answer. And we need to be realistic about how often we collect this, but also the value of collecting it, and find that kind of middle ground between the value of collecting this data on a regular basis and making sure it's updated, but also the impact that would have on research. Because the reason for collecting it is going to be really important, both from a public perspective, but for researchers collecting it. As Ashley said in our group, researchers do want as much data as possible, but the impact of asking and collecting more data for the member of the public who's being seen, or for the health professional or the clinician who's working really hard. And over time, we need to be really careful about the expected value of this and the added effort that needs to be put into that. But anyone else in my group, Ashley, please do jump in. As I say, I'm not an expert in this area at all.
No, I think you summarised that really, really well, Alice. And I think it's the balance for me, just to cover that last point of, I'll take the blame as a researcher, but we had some members who work in the NHS in our breakout, and public members. And I think we've all got to be realistic about, we all want more data, as much data as we want, as much as we can get our hands on. But what really is the implied benefit of collecting it every day, every time we see patients? So we have to all kind of come to that balance of how often is good enough to come up with a good answer, and to be able to support people and services to answer these types of questions. And also around I think we've all discussed now today around ethnicity and race and country of origin and other types, but it's also probably not realistic to have a patient sit in front of you and ask them, could you define yourself in 5 or 6 different ways to us, please? Because in a lot of cases, I know, speaking personally, I probably wouldn't know how to define myself in 5 or 6 different ways, even if asked. So I think there's a lot of training and support around this that we need to give to the people collecting the data, but also the people being asked to provide that data to us.
Great. Shall I pop and summarize for the final group? So I was joined by Marta, Sarah, Rose, Jackie, and Richard. And we all agreed that, the current capture really is a labyrinth. And, there's over 400 codes reflective of diversity and ethnicity. There's different ways of recording these. And there's just real heterogeneity at the very basic levels of the data. So we spoke about the importance of sort of context and connotations quite a few times, raising key questions around whether classification could be context specific, i.e. someone might answer differently whether you're asking a cultural question versus a healthcare versus education versus financial. You can imagine situations where you would answer quite differently. And then when thinking about sort of improving the capture of ethnicity data, we talked really in two bins, if you will. And the first was, standardizing what's already been collected. And so we had sort of an idea of, work to move forward, and a gap to fill is to really compare standardization approaches between groups. We've already had a few different approaches presented just on this call today. And so how can we bring those together, test them, and try and harmonize them so that, researchers have one that they can work from. And then looking at standardizing what is going to be collected, we talked, and Ashley just touched on this a bit, about the importance of the conversation between the data collectors and the participant, and how do we improve that conversation so that we're actually collecting better quality data. And there is training and support that's required around that. And sort of cross-cutting across both of these buckets, if you will, we then discuss, a more general lack of documentation and mapping to determine how codes are defined and applied. And, there was a suggestion to improve that by using an index, which could just simply describe what each group is. We also had a similar conversation to others around the difference between ethnicity and race, and we all agreed that the distinctions really are not clear to many people. And the confusion can come from the side of ethnicity, especially given that it's considered to be more social in construct. And there were suggestions that perhaps we can update the definitions to make them more encompassing, but again, relating back to that sort of training and support, that maybe there's a need for a wider education project to help people understand those key differences. And I open up to my group to add anything I might have missed.
A good summary, thank you. Oh, so just possible that what we should be doing is explaining the benefits of why we are collecting the data, because there's a lot of suspicion and concern in the public.
Thank you, Richard.
That's great. Thanks all. So just conscious of time and just trying to get wrapped up now, just doing a quick review. So just to say thank you again to everybody who stayed on for the breakout sessions and contributed to the discussion. It's really helpful, and just from the short summaries from the facilitators, it sounds like there's some great discussions there and some items we can use to take forward the challenges and the opportunities in this area. What we'll do as a group is we'll collate all of the discussion points and some of the actions into a short report, similarly to how we did after the first workshop. And hopefully, I'll look in Paula's direction here, but hopefully we'll have that up on the website in the next few weeks or so. We also plan to run another workshop later in the year, so keep an eye out for that as well. But Paula, do you want to just remind me roughly when were we thinking for the next workshop?
Yes, the next workshop will be in July. I think we can post the information soon on the website. So we will circulate. It probably should be around mid-July, but I don't have the date with me at hand. But we will post everything on the site, and you will be the first ones to be invited and receive the information. Oh, here you go. Claire has posted the time, 7th of July, 1 to 3 p.m. And we will, of course, send the invitation along. What we will also do, I think, once we collect all of the outputs on the website, and that will be the summary of the meeting today, we'll probably start thinking about a set of framework or a write-up that we would like to have as an outcome of these meetings, and we'll probably share it with you as well to input.
Brilliant. So I can see some people popping their contact details as well in the chat, but we'll make sure we share myself and Sarah and Rose and Cameron's details when we share the presentations as well, if anybody wants to make contact with them about that current work or any other work that's ongoing in the community. So yeah, so wrapping up exactly on time, which is great. So if anybody does have any further questions, then feel free to get in touch with Claire or Paula after the event, or myself. And yeah, just thank you again all for coming and contributing your time to this really important discussion, and hopefully look forward to seeing you soon again in July at the next workshop. Thanks all.
Thank you.
Thank you. Thanks, Ashley.
Bye.
Good afternoon.